Welcome everyone to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Noha Abalada from Roots Community Health, reporting for the week of October 6, 2025. As health professionals rooted in Oakland, serving some of the most marginalized communities in California, we're here to cut through the noise and bring you the latest information on health issues relevant to us all. As you might have guessed, the federal government shutdown, which began on October 1st, is having a direct and immediate impact on our ability to track some of our most critical public health data. We rely heavily on weekly surveillance reports from CDC and other agencies, and many of those data streams have now gone dark or are operating with severely reduced capacity this week. As a result of that, we unfortunately won't be able to provide the usual updates for this week on several key indicators. Those include the national or comprehensive data on COVID-19 hospitalizations and deaths and COVID wastewater surveillance. Also, the respiratory illness proportions, like the percentage of clinical tests that are positive for flu and the common cold, enterovirus, and COVID and RSV, and all of the related modeling, such as the maps that we look at for COVID epidemic trends. So we don't know when this information will be made available again. For now, instead of updated data, we are seeing this notice being displayed on many of the CDC's web pages. And it talks about that the current administration is working to reopen the government and so on. And so the key takeaway, I think, here is that even mission critical activities are now operating under severe limitations, and routine but important functions like weekly surveillance reporting and analysis have apparently been deemed non-essential and have been paused. And even though it's still early, flu season is getting underway, so the loss of this critical information is coming at a pretty concerning time. And in addition to this data being critical to shaping public guidance and education and so on, it's also used to inform local policy and resource allocation. So this is all pretty concerning, but it is the reality that we are currently facing. We're also seeing a stark difference in how state agencies compared to federal agencies are characterizing the situation. So for example, if you look at the California Department of Public Health website, you'll see a very different, although equally direct, message displayed in their banner. And this says the federal government has shut down due to the failures of the president and Congress to continue government funding. And it gives some specifics. And then it goes on to warn that we should be wary of potential highly partisan political messaging while visiting federal government websites for information related to the federal government shutdown. And I put a link to this in the post. So regardless of the political messaging being utilized at any level of government, our mission here remains unchanged, which is to protect the public's health with the best data and information available. And the reality is that we are losing visibility on important data streams at a critical time. And so this really puts the onus on local public health departments and health systems to rely on local indicators to continue guiding the public. And of course, the ability to do this varies greatly depending on the strength of those local efforts where you are until the shutdown ends and data reporting resumes. Now, while the data updates are paused, some key administrative decisions in public health did proceed. So the government shutdown did not deter some of this activity, as on October 6th, CDC officially adopted new immunization recommendations from its advisory panel, the ACIP. And of course, we reported on the ACIP's decisions a few weeks ago. But Acting Director Jim O'Neill approved the new schedules on October 6th, stating, "Informed consent is back," as he commented on two major shifts. So more on that in a moment, but first, the two major shifts. First, regarding COVID vaccination, the CDC has dropped its previous universal recommendation for annual COVID vaccine. The vaccination is now going to be based on so-called shared clinical decision-making, meaning that Americans, particularly those under 65, will need to consult their healthcare provider to determine their individual risk and benefit from getting the shot. It's important to note that this change runs absolutely counter to the overwhelming data that the benefits of COVID vaccination outweigh the risk in every age group. The second is regarding childhood vaccines. So CDC now officially recommends that toddlers receive the chickenpox or varicella vaccine separately from the combined measles, mumps, and rubella shot or MMR shot for the first dose. And so this change from the combined MMRV shot is based on a slightly higher risk of febrile seizures for young children with a combined injection. So here, instead of relying on shared clinical decision-making with providers to determine if the MMR V or the MMR plus the varicella should be given separately. Instead of doing clinical decision-making here, we're going to eliminate that possibility and mandate the additional injection. Whereas with COVID, we're going to require shared clinical decision-making. So it doesn't really seem to follow any logical pattern. And frankly, as a physician, I find O'Neill's framing about informed consent is back to be rather disingenuous and insulting. There has never been a point in time when shared clinical decision-making was not fundamental to patient care. So in reality, the new guidelines or lack of guidelines do not actually hold physicians to any new or higher standard. Instead, the CDC is lowering its standard. It's abdicating its public health duty to issue clear evidence-based population recommendations, while insinuating that physicians have not been doing informed consent or shared clinical decision-making all along. So now turning to a critical infectious disease that highlights the real world consequences of vaccination gaps and that puts the CDC's latest childhood vaccination guidance into perspective, let's take a look at our escalating measles crisis. The latest data, which is current as of September 30th, confirms that the U.S. outbreak is still going strong. So this is updated compared to last week when I reported, but this was immediately before the government shutdown. So I do expect that we will have a pause in this reporting as we move forward. But this is updated data that shows that we now have 1,544 confirmed cases reported across 42 jurisdictions so far this year. For context, this represents the highest number of cases in the U.S. in over 30 years. The outbreak remains widespread with several new hotspots that are drawing national attention. First, in the state of South Carolina, they have just confirmed a new outbreak in its upstate region. Health officials have confirmed that this outbreak includes cases associated with a school. And we know that this generally dramatically increases the risk of wider community transmission. Cases in Minnesota continue to rise. The state has seen major outbreaks this year, and one of the state's most recent patients is a hospitalized child. Georgia is also dealing with several cases, including 3 new ones recently tied to exposure at the Georgia State University area. And the large outbreak in Arizona now has a total of 59 cases, including 1 hospitalization so far. And this is all happening as the entire Americas region is on the cusp of losing its measles elimination status. So the Pan American Health Organization, or PAHO, which is the Americas arm of the World Health Organization, has sounded the alarm. So under the PAHO definition, a country must stop local transmission and get back to 0 cases within 12 months of an outbreak starting. So the deadlines for this elimination status are rapidly approaching for the 3 major countries. Canada's deadline expires this month at the end of October. The United States has until the end of January, and Mexico has until the end of February. The current wave across the continent is pretty staggering. The United States has over 1,500 cases and 3 confirmed deaths this year. The regional total of confirmed cases across the Americas is already over 11,300 cases this year. The fact that the U.S. is facing this crisis while also being in the process of officially quitting the World Health Organization, although we are still members of PAHO, but this only adds to the global uncertainty surrounding vaccine preventable diseases. And lastly, in terms of the government shutdown's impact on healthcare, I will just point out a few highlights. So first, in general, Medicare benefits will continue uninterrupted. Medicare is a mandatory spending program, meaning that its funding is guaranteed by law and does not require annual approval by Congress. So that is a bit of good news. You can still see your doctors, you can get prescriptions, you can enroll in Medicare. But because about half of the staff at CMS, or the Centers for Medicare and Medicaid Services, are furloughed, administrative functions deemed non-essential will be delayed. And this includes tasks like reissuing Medicare cards or certain patient casework. And while the Medicare hotline is still operational, wait times are expected to increase. And a prolonged shutdown would eventually lead to major delays in payments to healthcare providers. So we hope that that will not come to pass. But if the shutdown persists, we will see even broader impacts still. This is especially true for programs that do rely on annual appropriations that have now expired. And these include the Community Health Center program and the National Health Service Corps, both of which face an immediate funding crisis. They are working off reserves, is the best of my understanding, but this does represent a funding crisis. The Supplemental Nutrition Program for Women, Infants, and Children, otherwise known as WIC, has limited contingency funds. It will quickly become unable to serve its 6.5 million beneficiaries. The NIH, National Institutes of Health, will stop admitting new patients into clinical trials and will stop processing new grant applications. The Children's Health Insurance Program and Medicaid are expected to continue operating using reserved or set aside funding for at least the short term. And finally, the government shutdown has coincided with the expiration of numerous temporary COVID-19 public health emergency telehealth flexibilities that Congress did not extend. So although this policy change is actually independent of the shutdown, it took effect on the same day, October 1st. So for most of these services, Medicare coverage has gone back to the pre-pandemic rules, which were very restrictive. And this means a significant reduction in covered services for millions of beneficiaries, as they're once again going to be limited to receiving telehealth only in certain rural areas and at specific facility-based sites. So this is very long ago type of provisions that we're getting dialed back to right now. Fortunately, telehealth for mental health and behavioral health services remains largely protected. Audio visits are no longer covered. And for now, some services are being curtailed, while others are, and this meaning that healthcare providers are stopping these services, these telehealth services right now, because there's no guarantee that they will get reimbursed, while others are still providing them, but the bills are being held in the hopes that once Congress reconvenes, that they will authorize a retroactive reimbursement for those services, but there's absolutely no guarantee that that will happen. So the one potentially silver lining is that there is strong bipartisan support for extending telehealth. So this does give us hope that this lifeline will be restored in a new spending bill once the government reopens. But in the meantime, this temporary loss of access is resulting in reduced care for some of our most vulnerable community members and potentially increasing the burden on our already constrained health systems. And there's no question that we are navigating turbulent public health landscape right now. We have failures all around us. We have institutional failings, we have policy gridlock, we have service disruption, we have a reduction in access, and more pressure being placed on constrained systems by saying we have to do shared decision-making for things that had guidance previously. So now we are no longer able to lean on our pharmacist partners, for example, to implement CDC guidelines, because everything is going to be putting pressure on primary care and ultimately also on emergency rooms and emergency departments in hospitals, and of course, cutting off telehealth is only adding to that crisis as well. But amidst all of that, we can still do all that we can to engage in best practices to keep ourselves and our loved ones and our community as safe and healthy as possible. And remember, if you don't have a primary care provider, please get one. Know how to reach them before you need them. And remember to eat a balanced diet, stay well hydrated, quit smoking, limit your alcohol intake, reduce those simple sugars and processed foods and artificial ingredients. If you're sick, please rest and recover. We know that pushing yourself and trying to go back out to full steam can actually impair your recovery and may be even associated with post-viral conditions. Otherwise, get some regular physical activity and some fresh air. Manage those stress levels and get a good night's sleep. This concludes today's People's Health Briefing. We will be taking next week off, and we look forward to seeing you again on Tuesday, October 21st at 10 a.m. See you then.